The next speaker is Devangere, good friend and colleague for many years. One of the leading psychiatrists, Alzheimer's researchers at Columbia University, and done a lot of work. Both with the Columbia team and the Reswami here and others on interventions and targeted training for patients with age-associated memory impairment.
Thank you, Anand, for that flattering introduction. And I'd like to thank the organizers, Igor, Dr. Reswami, and others for inviting me here. Actually, I've never been to Duke before, ever, as I recall. And I'm very impressed by the people as well as the physical facilities. People in New York at Columbia would kill to get a facility remotely like this. So I'm going to talk a little bit about neuropsychiatric symptoms and their treatment in Alzheimer's disease, touch a little bit on disparities. I say a little bit because there's very little study of that issue in this particular area. This is my disclosure. I'm a consultant on or a DSMB member for some of these companies. Most of my studies that I'll present have been funded by the National Institute of Aging and to a small extent by the Alzheimer's Association. You saw this described by Dr. Anand Kumar earlier. The beta amyloid deposits and neurofibrillary tangles. These are extracellular, and you can see these are intracellular. Each of these is a neuron. Neuron goes like this. It's cut cross-sectionally, and you see the tangle is inside with sometimes a little space around it. One of the interesting things that fits in with Anand's presentation earlier, the number of amyloid plaques shows little correlation with patient's cognitive status just prior to death. Tangles, the neurofibrillary tangles, show a moderately strong association. So the pathology does not correlate one-to-one with the clinical features of the patient prior to death. It simply doesn't. So when we think about dementia, I've used the word dementia broadly. Most of this pertains to Alzheimer's disease. We think of it as plaques and tangles, some unitary phenomenon or binary phenomenon, anything you want to call it. But clinically, this is what we see. Everybody agrees on this. The medication toxicity and medical comorbidity influences the clinical picture. Some people are taking these drugs, cholinesterase inhibitors and memantine, some are not. That may alter the degree of cognitive impairment we see. Neuropsychiatric symptoms, which will be the focus of my talk, for which we have specific and judicious use of psychotropics. But then we also have lifestyle factors, cognitive training, physical training. If you look at the magnitude of cognitive training, it's somewhat smaller than effect size, like effect size like 0.1, 0.15. If you look at physical training, physical exercise, even in trials, you're getting effect sizes of around 0.2, which is higher than lecanemab or donanemab. So one of the difficulties, of course, is implementing these things. What people need to do, most people either cannot or will not do in terms of the level, intensity of cognitive and physical training, which in clinical trials is pretty intense compared to what people normally do. Control of vascular risk factors. We think of Alzheimer's disease as a unitary phenomenon. If you look at pathological studies, we looked at the NAC database, which is the consortium of 39 Alzheimer's centers, where pathology is done for whoever agrees to it. Pure Alzheimer's disease is less common than Alzheimer's disease with additional neuropathologies. Vascular pathology, Lewy body dementia, other types of neuropathology. Therefore, controlling vascular risk factors is critical. In fact, the entire field of disparities in terms of Alzheimer's disease has not addressed this confound. They're trying to do it now, one of which is a study called the Offspring Study at Columbia. Is it that African Americans and Hispanics had more diabetes, more hypertension, more obesity, other risk factors? Yes. Has that been accounted for prospectively rather than in covariance analysis to see whether the increased rate of Alzheimer's is really an increased rate of Alzheimer's, or is it an increased rate of multi-infarct dementia in combination with Alzheimer's? We don't still know the answer, even though this studies have been going on, because it hasn't really been studied prospectively, and hopefully we'll know the answer to that in the near future. Caregiver interactions and coping make a big difference to the clinical picture of patients as the disease progresses. And there's considerable variability. It has been studied, but not sufficiently to date. So we think about disease progression in terms of who stays at home, who goes to a nursing home. We heard about that in the previous talk, that people of Asian origin, the patient tends to stay at home rather than be in a nursing home. But if you look at what leads people to go into a nursing home, the most common antecedents are agitation, wandering, incontinence, and psychosis. 3 out of the 4 most common reasons, and this is for studies done in the US, Sweden, and Japan. So it's quite consistent across cultural backgrounds. 3 out of the 4 reasons, most common reasons for a patient being admitted to a nursing home is psychiatric symptomatology: agitation, wandering, psychosis. It is not progression of memory loss. It is not inability to initiate activities at home or do anything. Family members accept that. They handle it, but they cannot handle these issues: agitation, wandering, and psychosis. Very difficult. And a variety of studies have shown that patients who develop these symptoms have worse quality of life, greater impairment in activities of daily living, obviously increased caregiver burden, increased costs, and more rapid dementia progression with increased mortality. So if a patient begins to get aggressive or psychotic, it's a very poor prognostic sign. It's not clear why that is the case. It hasn't been shown that these people at autopsy have more severe amyloid or tau pathology. One of the reasons may be a fairly simple one to explain. Caregivers are no longer able to care for the patient in the same way. Patients are uncooperative, aggressive, things change. So the day-to-day things that caregivers do to maintain a patient with dementia become very, very difficult to execute. And as a result, the patient's prognosis is worse. This is talked about. Nobody has studied this prospectively, but it makes some sense. So I'm going to talk a little bit about psychopathology in Alzheimer's disease. What is this? How does it relate to what we see in other psychiatric disorders? And you'll see that the symptoms listed here cover the gamut of symptoms that we see across a variety of other conditions. I'm going to illustrate this with a study that we did years ago, and it's been replicated in different settings, clinical settings, community settings. So it's fairly consistent in the literature. So what we did was we took 236 patients with mild to moderate Alzheimer's disease, defined by Mini-Mental scores of 18 and above, saw them every 6 months to map the course of illness. These are people already diagnosed clinically with Alzheimer's. This is an older study, so it's a clinical diagnosis, no biomarker diagnosis. And one reason you can do this is for an unfortunate reason, which is we don't have effective treatments for Alzheimer's. So when you follow people chronologically, you're getting a pretty good representation of the actual symptoms during the course of illness. Because it's not like schizophrenia or depression or mania where the treatments confound the natural course, at least these days. The first thing we saw using a scale that I developed called the CUSPAD, Columbia University Scale for Psychopathology and Alzheimer's, very simple one. Actually, it was designed purely to keep it very simple for this study so that research assistants could administer it without having to do a sophisticated DSM diagnosis. The majority of patients at the mild to moderate stage had one or more psychiatric symptoms, the list that I described. So this is the norm rather than the exception. And during the first 3 years of follow-up, almost everybody had one or more of these symptoms. So the next half a dozen slides have the same metrics. The y-axis is a percent of people who have that symptom. The x-axis is time points, 0 baseline, 6 months, 1 year, 18 months, like that. These are point prevalences. It's not necessarily the case that the same patients in one graph are showing up at the next time point in the next graph. So if you see paranoid delusions, 15 to 20% of patients get paranoid delusions. The most common symptom is somebody stealing my things, occasionally suspicion of infidelity in the spouse. Hallucinations are less common, only about 5 to 10% of patients. It could be visual or it could be auditory. You also get somewhat vague symptoms. It's not clear if the patient is hallucinating because they don't say anything, but then they behave in a manner that they're responding to a stimulus in the environment or hearing something. Agitation or wandering, all of you can see this loud and clear because it's by far the most common symptom. Physical agitation or tendency to just wander out of the house. So this is often the target of intervention. Physical aggression towards somebody else is quite uncommon, especially in the early stages of illness. So if somebody presents with either aggression or hallucinations, we have to think of something else. It probably isn't Alzheimer's. What about depression? One would imagine that if a patient is learning that they're losing their memory, they're maybe getting a dementia, progressive disease like Alzheimer's, they will get very depressed. The prevalence of depression does not change during the course of illness. About 20% have some degree of depression. It's just depressed mood. And if we look at depressed mood with neurovegetative signs of sleep and appetite disturbance, it's really uncommon. Only about 5% have that. So the type of depression we see is usually not classical major depression or what we used to call endogenous depression. The theory behind why people don't get depressed once they learn that they have this progressive disease is that to some extent, the cognitive elements of self-awareness are also being lost with disease progression. So it's not uncommon for patients in the moderate stages of dementia, if you ask them about their memory, they will actually report it as being better at that stage than when they talk to you at the mild stage of illness, where they were more aware of what's happening. That may be one of the reasons why depression is really not that common. So to just summarize this section of the talk, most patients with Alzheimer's disease develop psychiatric symptoms. Psychosis and agitation often co-occur in Alzheimer's disease and lead to institutionalization. Agitation is common, persistent, and increases with disease severity. Aggression is quite uncommon in mild stages, but does increase with disease progression. The psychotic features and depressed mood, they don't really change in prevalence over time. It's not that the more impaired you are cognitively, the more psychotic you will be. That's really not being shown. And the classic neurovegetative major depression is really quite uncommon. And this is a clinical follow-up study we did. It's been replicated in epidemiological studies, slight variation, but really not very much. Now, why does all this occur? One simple theory, which is difficult to prove, there are a few imaging studies indirectly supporting this, is that if you look at the brain, this is the frontal cortex, which in humans is highly developed compared to other mammals. And with Alzheimer's disease, there's degeneration in the frontal cortex and other cortical structures. These are largely inhibitory for subcortical structures in the midbrain basal ganglia. So as the disease progresses, your ability to inhibit, say, aggressive impulses, which may be arising from subcortical structures, is gradually diminishing. Similarly, motor control is gradually diminishing because your cortex, which inhibits these centers which keep firing all the time, is degenerating. That may be why over time you get increased agitation, increased aggression, increased impulsivity. Now, I took a quick look for this conference at what we know about health disparities. And this, you can't see this very well, but just to summarize, this is a study out of Venezuela where they had 530 people from 2 rural areas who had dementia. And you don't need to see the details here. Essentially, the rates, there's anxiety, irritability, and agitation, aggression. The rates are very similar to what we see in the United States. It's really not very different in Venezuela. And if you look at the association between neuropsychiatric symptoms and dementia, it's really similar to what we have seen. Like agitation, aggression is prominent here. Sleep problems, are there hallucinations? Not very frequent. Depression, not very frequent. Delusions, moderate frequency. So, and other studies done around the world essentially showed that Alzheimer's patients, assuming they're diagnosed in a comparable way, have pretty similar psychiatric symptoms across the world, also suggesting it's probably related to progressive brain pathology and not necessarily to the patient-caregiver interaction or cultural factors. Now, this is from the NAC database, which is the National Alzheimer's Consortium of Centers. And ethnic groups have a similar prevalence, but there's greater use of antipsychotic medication in Hispanics, to some extent African Americans. So there is this disparity in that for whites, it's more likely that the initial intervention will be a behavioral effort. Working with a caregiver, we often educate the caregiver about the patient. A simple example I can give you, it's prototypical. The patient, he was getting a bit agitated, a bit hostile, saying certain things. And his wife was really upset because she felt he was raking up old issues and just trying to turn the screw and needle her about certain things. And the conversation I had with her was, your husband has a brain disease. That is why parts of the brain are being damaged and some old memories are coming up. It doesn't mean that she felt he had a deep-seated resentment for 30 or 40 years. He really hated her, and now it's coming out. So having these kinds of discussions with caregivers requires time. And I think we don't really have good data on this, but these data would suggest that for African Americans and Hispanics, there's less of an initial attempt to have these conversations with caregivers and go quickly to the antipsychotics, whereas for whites, it's more, let's have this caregiver education approach first before going there. I don't know if that's the case, but indirectly this suggests that. Now, this is a study from New York City, SUNY Downstate Medical Center in Brooklyn, which has a large African-American population. So this is from Carl Cohen's group. So as you see, their center, and I've given a couple of talks there, they have, in this series, 568 Blacks, 197 white. So it's like 75% Black. The breakdown of dementia subtypes, this was clinical, not biomarker based, is consistent with the general population. Alzheimer's, a little over 70%, vascular dementia, and then mixed dementia and other dementias. And what he did, which was quite interesting, and it's a simple way to look at what happens chronologically in populations. He took 3 time periods, late 90s, turn of the century, 2003 and 2008, and looked at the documentation, medical records. Blacks had more severe dementia and psychosis in period 1 in the 90s, but differences disappeared by period 2 and period 3. Does it mean that the patients changed? Indirectly, probably means one thing. In the 90s, because Alzheimer's was not very much in the public mind, patients are probably being brought late to the clinic at a more severe stage because they felt nothing could be done and let's hang on and see if somehow we can manage the patient at home. Whereas in the 2000s, people are more aware and are more likely to bring the patient in a bit earlier, just as now we see huge numbers of patients with mild cognitive impairment or MCI. 20 years ago, that was much less common than the more severe Alzheimer's patients. So that's a bit of a change over time, which is not related to any, I don't think it's related to any particular population, but it just happens. I'm going to talk a little bit about treatment studies. I just want to make a comment about some of the other things we've heard yesterday and today, including in our earlier talk just prior to mine. The sample sizes in epidemiological studies and medical record studies, say CMS Medicaid database, hundreds of thousands, millions. Clinical trial of lecanemab, 800 or so, 900 patients per group is obviously a lot smaller. The studies I'm going to show you are even smaller than that. However, actually that's fine because we think about number of patients, but what is the study design? That's the fundamental difference. Randomized, flip of a coin. When you randomize, sample is even medium sized, not even large, it washes out differences between the groups if it's properly done, a true randomization. So you're not going to get different comorbidities in a sample size of 800. In fact, I'm pretty sure in the lecanemab trial, there was absolutely no difference on any of like 25 demographic and clinical measures between the randomized groups. That's randomization. We don't have that opportunity looking at the MDS and nursing homes. You can't control anything. Double blind. We don't know, patient doesn't know what they're getting. Placebo, which many patients and everybody finds strange and maybe a bit harsh, but you need that. So when you put in a randomized double-blind placebo-controlled trial, it puts the bias, you still can get some bias, but it really reduces it to such a low level that the likelihood of getting a positive result is very, very low, which is why these last 2 or 3 trials have shown a positive result, as Dr. Anand Kumar pointed out, but there were 100 previous trials that showed nothing. And in fact, some of the previous trials, a couple of them, showed that the placebo was better than drug. Again, that could have been chance. We don't know. So I just want to point out that when we see smaller sample sizes here, all the studies I'm going to talk about are randomized, double-blind, placebo-controlled trials. And that's how we can actually work with relatively small samples. Now, I'm going to start by looking at antipsychotics because they're widely used, controversial in this situation. And one of the odd things about Alzheimer's disease is many people are agitated or also psychotic. But because the symptoms of psychosis are not like classical schizophrenia, what has happened is in the studies, if patients improve on antipsychotics compared to placebo, the psychosis improves, the agitation improves, the aggression improves. You don't get specificity. And I think that's because the type of psychotic symptoms Alzheimer's patients have, suspicious that somebody's stealing my things, suspicion of infidelity, is completely different from a patient with schizophrenia who's paranoid about somebody coming to poison his food or being spied on from somebody, with a television camera in the trees having been sent by the CIA. It's very, very different. And we don't really understand that very well. But clinically, the agitation and psychosis show similar response rates. Now, when we talk about drugs, we always have to think about side effects and toxicity. I should point out that's one of the reasons why we want to try and do behavioral changes in caregiver education before we go to this level of using a drug. But clinically, when a patient is very psychotic, very aggressive, something has to be done. And if the behavioral methods don't work, this is what we're left with. We know that elderly people are at greater risk of extrapyramidal signs, tardive dyskinesia. And it varies by the type of antipsychotic used. Interestingly, because we use very low doses, and that comes out of some of these studies I'm going to describe, some of the peripheral side effects, orthostatic hypotension, autonomic side effects like dry mouth, constipation, urinary retention, are really quite uncommon because we're using very low doses. However, there is a bigger problem, which is that there's an increased risk of mortality in dementia with the use of antipsychotics. The relative risk is 1.6, moderate, and it's not fully understood why there's an increased risk. There was a thought that maybe higher risk of stroke, but other studies haven't shown that. The most likely explanation is a fairly simple one, and studies indirectly suggest this. When you give an antipsychotic, the patient gets some degree of sedation. An elderly patient, especially in a nursing home, more sedation, less mobility, more likely of bed sores and pneumonia. They will die from it. It's very difficult to study this prospectively, but that's the sense of what may be happening. But there is an increased mortality risk. If we're going to prescribe an antipsychotic, we inform the patient, if competent, or the caregiver or the family member, that there is an increased mortality risk. So I do have a slide on the CMS database to be in 5 minutes. Okay. To be in sync with the rest of the presenters. This was a very nice study done by Krista Hybrex from Harvard. Evaluated 75,000 patients in the CMS database who got antipsychotics. And there's a slight difference between drugs. Haloperidol, an older drug, had the highest mortality. But the critical factor was dosage. Within each drug, risperidone, olanzapine, or haloperidol, the higher doses were associated with higher mortality. So the whole point about not just which drug, but what dose to use is quite critical. Then there's the issue of antipsychotic discontinuation. We did this study, people got open treatment for 16 weeks, then they were randomized in this manner. And to just cut to the chase, when patients were withdrawn from antipsychotics, meaning they switched from drug to placebo, the other group continued on drug, there was a greater risk of relapse. suggesting that the antipsychotic actually was effective in treating psychosis or agitation. We did that at 2 time points. It was sequential, randomized design. We saw it at the later time point as well. So we get into this dilemma of you keep a person on an antipsychotic drug, the side effect problems over time. But if you withdraw the drug, they're more likely to relapse. And this is the typical clinic problem faced by physicians when they deal with patients. How do you balance the efficacy and side effects? And it's a difficult problem, and we don't have an easy solution for it. CMS has added a stipulation to reduce the overprescribing of antipsychotics that within a nursing home, not more than 15% of patients should be on antipsychotics. Not sure exactly how they're monitoring it. They do come and make some periodic surveys, but that's the goal. The difficulty with that is, it's not that the physicians are taking them off antipsychotics. They're switching them to anticonvulsants, most commonly gabapentin, benzodiazepine. So you say, I'm going to block the use of this drug because it's potentially toxic, it's overused. The regulator has to keep in mind that something else may be used, which may be even worse. Okay. What about disparities, the ethnicity differences? There's not much data. I went back to the main studies in the literature and looked at it. And most of the studies, in all these are US studies, I restricted it to US studies. About 70 to 85% are white. You do get some Black and Hispanic representation. Actually, the Black representation is much higher than the Hispanic representation. It just might be a chronological thing. Most of these studies were done 10, 20 years ago. This might have been a shift since then. So I think in terms of disparities, we don't see a huge difference. The one thing I would say is it looks like minorities, Blacks and Hispanics are more likely to be given drugs more quickly. But in terms of the outcomes and just who is participating in the clinical trials, I don't think there's a big difference. Obviously, greater representation would be a good idea, which is happening with the newer studies that are being launched. Thank you.
Behind you, one question? Learning question. You have learning question. Absolutely learning question. Right.
So, in a way, this is connected. So, in one way, you presented your scale, which in the very beginning of the presentation, which maps dementia severity or Alzheimer's severity. So the question would be, when you're using the MMSE, or when I'm using the MMSE, I never see the patient. Right? All I see is some scores. So there's a big difficulty in differentiating between someone who is inherently stupid, for lack of a better word, right, and the decline from that baseline, from someone who is declining from a higher level. So is the use of the scale that you propose helpful in solving that problem? Related to that, on the prescriptions of antipsychotics, and someone who is able to sort of look in at the local culture from the outside, you can label patients. So just from personal experience, your average white American tends to be more quiet and repressed, whereas your average ethnic American tends to express their emotions more often. And if you're expressing your emotions within the general cultural space here, you're obviously crazy, right? So what do you need? You need some drugs to calm you down. And do you think that's a possible consideration?
Okay. So to address the question about MMSE, the scale that I was describing was looking at psychiatric symptoms, not the MMSE. But you bring up a good point about the MMSE or any cognitive measure. What is the baseline? That's why we would love it if everybody in their 20s or 30s did a brief neuropsych test battery and we know where they started at. Education has a very big impact on these cognitive measures, including MMSE. We try to control for it, but it's not as good as actually getting the measure initially. So it's a problem. we recognize it, it's tough to control. In terms of cultural effects on behavior, they do exist. But if you look at the prevalence of these various psychiatric syndromes in different ethnic groups, they're very similar. And I think part of the reason is, I showed you the picture of the brain. If the person is having significant brain pathology, that results in symptoms that literally override the person's cultural background. May not be in the mild stages, but certainly in the moderate to severe stage.